Welcome, everybody. My name is David Barron from Sick Kids Hospital in Toronto. I'm very sorry I can't be with you today, but thank you very much to Dr. Das and to the Society for the invitation. Let me just share my screen. So an interesting topic for debate today around really the choice of technique that we use for the Fontan and really what evidence there is, perhaps whether we should revisit the strategies that we're using. I have no disclosures other than to tell you that I can't pretend that I'm not a strong proponent of the extracardiac conduit, but I'll try really and show the data to you as objectively as possible. So here's the great spectrum of patients with functionally single ventricles that we treat these days, and we treat them very successfully in that really, although single ventricle diagnoses really only account for about 3 to 4% of all congenital heart disease, they occupy a great amount of our time as surgeons because pretty much all of them need a whole series of staged procedures to take them through to their Fontan circulation. And despite whatever their morphology or particular makeup of their heart is, they all have a final common pathway of the Fontan circulation. And really, it's so common now that if you look at all the pediatric surgery and how much of it is done in neonatal and infancy, that really when you look at all the types of operation that are done after the age of 2 years, the Fontan is actually the commonest single procedure that we perform as cardiac surgeons in children over 2 years of age. So it's become a very important part of what we do. And of course, the TCPC, the total cava pulmonary connection, is very much the definitive way of providing Fontan circulation. The lateral tunnel was the first kind of invention of the TCPC by both Mark Delaval and Francisco Puga in the Mayo Clinic, all around the same time in the late 1980s. And the idea being to create a lateral baffle within the right atrium so that it channeled the IVC blood through to the pulmonary arteries, using the atrium itself as a conduit for the blood. And the extracardiac conduit came really just a few years later and was first really described by Marcelletti in Rome in 1990. And it was attractive and has become a very attractive option, the extracardiac Fontan, because it completely excludes the atrial tissue from the high venous pressure of the Fontan circuit. It's also attractive because it can be performed without needing to cross-clamp or any ischemia for the ventricle. There are less intracardiac suture lines, so a combination of that lack of stretch on the atrium and a lack of suture lines hopefully means less risk of arrhythmia. And it's also a very adaptable technique because you can use it in all sorts of different anatomies. It's done as a staged procedure and it's done with a fenestration, as that has almost become the definitive type of Fontan circulation that's most commonly used around the world today. And you can see, why it's become so popular because the results that are published out there with large series do strongly support the use of the extracardiac Fontan. These were data from both Birmingham and from Melbourne, where certainly you see the benefits of the extracardiac Fontan, both in early and late survival. And particularly if you believe that the extracardiac Fontan gives you a real benefit in freedom from arrhythmia, equally, as the longer term outcomes have been published for the extracardiac Fontan, it certainly seems to have a benefit in terms of less particular tachyarrhythmias when you compare it to the lateral tunnel Fontan. But all these results are difficult to interpret in the sense that there is almost always an era effect. Because the lateral tunnel came before the extracardiac, then we have to be careful of not compounding a simple era effect in terms of interpreting the outcomes. The era effects are very clear in the Fontan. We've got much better at doing the Fontan and providing a safe, secure Fontan circulation over the years. And the survivals by era have constantly improved, such that the current era survivals are really extremely good, regardless of which type of Fontan circulation you choose. And if you look at this curve on the right side of the slide here, Boston looked at all their data and they excluded all the early mortality. And as soon as you did that, you could see that actually whichever technique that you used didn't really make much difference. And similarly, here's the big Australia New Zealand registry, which is over 1,000 patients. And you can see that if you exclude the early mortality, which is effectively the biggest component of the era effect, then you can actually suddenly find very little difference between the extracardiac conduit and the lateral tunnel in terms of both their sort of medium and long-term survival. So the difference clearly is pretty subtle between the two techniques. And I think you can't forget, of course, that there is a natural history of the Fontan state superimposed on these procedures, regardless of which technique you choose. This is Fontan's own curve, remember, where he chose his very best Fontans who had the very best underlying physiology. And even he came out with this very clear and smart observation that the Fontan state is a gradually declining functional capacity, because it's really the effect of living with a chronically high systemic venous pressure. The human physiology was designed with two ventricles for a reason, and to survive with a single ventricle circulation comes at the cost of gradually declining functional capacity. And as we looked in Birmingham at the real things that really impacted on outcome for the Fontan, and you can pretty much distill them down to two factors: good ventricular function and low pulmonary vascular resistance really trump everything in terms of your Fontan performance. And we've got so much better over the years at keeping our patients with good function and making sure that we protect the lungs, that they don't get damaged, that don't develop high pulmonary vascular resistance, that in a way has probably been far more important than the subtleties of the type of Fontan circulation that we choose. And exactly the same conclusion that comes from some Toronto data looking at 500 Fontans. When you looked at risk factors over a 35-year period, the risk factors for death are ventricular function and pulmonary vascular resistance. And really, the type of Fontan actually is far less important. So you can kind of conclude that the Fontan outcomes have become excellent in the current era. There's no doubt the extracardiac conduit is the most popular technique, and there doesn't really seem to be very much difference between the two types of extracardiac versus lateral tunnel, although probably less of an arrhythmia burden with the extracardiac conduit. And I could have stopped there, but this paper came out from the STS data a few years ago that kind of quite surprisingly suggested a slightly less mortality and less Fontan takedown with the lateral tunnel compared to the extracardiac conduit. And then this paper came out from Boston just a couple of years ago, where Boston analyzed all their data, and they showed again a survival benefit from lateral tunnel compared to extracardiac conduit, which was not really, it was running against the flow of most of the data that was out in the literature at the time. And you have to be a bit careful interpreting this, because there are much lower numbers of extracardiac conduit than the lateral tunnel in this series. But nevertheless, it was an important observation and made us stop and think, and hence really the title of this talk today. And why might it be? Why might the lateral tunnel be slightly better or have better physiology? And certainly some of the flow modeling that was done early on by Mark de Laval certainly suggested that by doing a hemi-Fontan followed by a lateral tunnel Fontan, so the hemi-Fontan followed by the lateral tunnel, maybe suggested you got much better sort of flow dynamics in this passive flow circuit, the Fontan circulation. So you got much less energy loss when you compared the lateral tunnel to the extracardiac conduit, and you got much better flow distribution to each lung with this type of arrangement than with an extracardiac conduit. So maybe there are some subtle physiological reasons why lateral tunneling may be better. So, okay, let's just look. That's made us all stop and think over the last few years. There have been 3 meta-analyses to try and look to see whether is there real evidence out there to suggest that lateral tunnel or extracardiac is the better technique. And these sort of big meta-analysis is probably the best we've got because there is no randomized trial. So let's look at these three meta-analyses. This was from Dudechem, where they chose only large studies in the recent era. So you had to be over 200 cases for them to include you in the study. And so they looked at 14 large studies over 7,000 cases, and this is their conclusion. Yeah, you could not show any difference in early or late survival comparing lateral tunnel to extracardiac, no difference in Fontan failure, and perhaps the only factor that came out was less tachyarrhythmias in the extracardiac group, which again makes kind of sense from what we discussed right at the beginning. And their conclusion was that really, despite decades of follow-up, we still don't really know which, if either, is a better technique. This is the second meta-analysis that was done by Nancy Poirier, and they looked at 12 studies, picked out more than 3,000 cases, and actually, if anything, they showed survival benefit of the extracardiac over the lateral tunnel, and certainly less arrhythmias in the extracardiac over lateral tunnel. And thirdly, the meta-analysis came out of China. Again, chose 10 studies, slightly different criteria, but again, the headline is no difference in early or late survival, regardless of which technique that you choose. If you look at tachyarrhythmias and overall freedom from arrhythmia, there is a benefit of the extracardiac conduit, but no difference in the pacemaker risk between the two groups. So bradyarrhythmias is much the same. So really, to conclude, from what I can tell, really from looking at all the data that we have, certainly both techniques have a really excellent outcome in the modern era. And that, truthfully, there's probably no discernible difference in terms of early or late outcomes or Fontan failure or Fontan takedown, whether it's lateral tunnel or extracardiac conduit. But there probably is a clear benefit in a reduced risk of arrhythmias with the extracardiac conduit. It's still true that the extracardiac is the most popular technique. Doesn't necessarily mean it's better, but it is the one that's most favored around the world. And that really, I think the reason behind all of this data is that really it's ventricular function and pulmonary vascular resistance that trump everything. So the difference that a particular type of technique makes is much more subtle and difficult to prove. And it's much more important that we look after the ventricular function and the pulmonary vascular resistance in these cases, and which particular type of Fontan that we choose. So my advice really would be, whichever Fontan you prefer, stick with it. If whatever you're comfortable with, that's the one you should stay with, because I think you can argue the case for each and do whatever you feel is the best technique in your hands. Thank you very much. I hope you enjoy the rest of the